All right, the Yellowstone City County Board of Health will come to order. Do we have any guests in the room that would like to address us?
He's in Mexico, so his IP might be.
Hearing none. Anyone online who would like to address the board? Hearing none, you have your meeting notes in front of you from last month. I get a motion to approve.
Approval. Second.
Any comments? Hearing none. The minutes are approved. You have a consent agenda
We approve.
in front of you. Second.
Second.
Any comments or questions? So moved. Done. If you're up. All right. They have comments about a recent event.
Good morning, all. I've got my report here in front of us. Before I do, I'd like to ask us to start off with a moment of silence this morning. We are eternally grateful for the life and service of County Commissioner John Ossom, who served our county with honor since 2002. He leaves a legacy of public service and commitment to this community, to closing the urban-rural divide, to advocating for youth, the ag community, and for sensible solutions facing our county. I personally truly enjoyed working with John and getting to know him for the short time that we were working together. I admired his commitment to community service, his willingness to listen to different viewpoints, and his strong moral compass that strengthened our county and everyone who knew him. If you're the praying type, I'd ask you to take a moment to lift up John, his family, his Yellowstone County colleagues in your hearts as our community continues remembering his service and grieving his loss. Thank you. Our community health needs assessment is now live. Please take the survey. Carrie will send you 2 surveys this month. This is one of them. If you want to just take one, I prefer to have 0 board meeting surveys this month if you take the community health needs assessment survey. There's your free pass. You'll only get it this month. But please take the community health needs assessment survey. We value your opinion. It takes between 10 to 15 minutes, depending on how much thought you put into it. And we need your input. So the link is in my report this week. Our collaborative, the Yellowstone Valley Childhood Advocacy Center, or our CAC, for victims of child maltreatment, recently received reaccreditation from the National Children's Alliance. And we also had last week a successful visit from the Montana Board of Crime Control, came to audit the money we spend through our VOCA funds with the state. So all good news there in strengthening that resource for Eastern Montana. We were recognized just for meeting all of their standards, making sure that children and families have access to effective, efficient, relevant, and compassionate services when they need them. There's Mr. Steve in his beautiful outfit. Thanks, Steve, for always coming to the golf tournament. Special thanks to Jim and to Coach Dorr for being our board volunteers and lunch hosts during the 2 days. We expect gross income to be about $100,000 after expenses. It always goes down, but not a bad take from our golf tournament this year. 43 teams joined us over the 2 days. We had beautiful days with no rain. Go ahead, Steve.
Hey, John. So I think the most important portion of that portion of the discussion was that that team of the Warlick team, Stella's team, and that was I think it was the 5th time in a row that we defended our championship, that we were the low gross foursome. So not bad for a really old fart guy. So I just wanted to throw that in there. Just, wanted to make sure I felt good.
we'll have Carrie make sure that makes it into the official record.
Okay, that's good. That's really good.
You may have a tournament in Marshallville with your group next year. Either Spencer or I may ride in the cart with you.
Oh, gosh. Over Memorial Day weekend, we had a busy IT team here on campus and off campus, completing our electronic health record upgrade. We upgraded our ECW system to the cloud out there in the ether, and the team just diligently planned and executed an almost flawless transition with only a few minor delays to patient care, which were also planned for and communicated with our care teams. Unlike some folks up the street that recently did an EHR upgrade, we're proud to say that we had the better team. RiverStone also launched some warm weather education campaigns to educate the public about tick-borne illness. Black-legged ticks have been now confirmed in Montana, and the black-legged tick is a known vector for Lyme disease and other tick-borne illnesses. So DPHHS has launched a new tick-borne illness page on their website. Giving you all the link there in the report. So we'll continue to monitor those potential impacts. A few weeks ago, we also held our annual Women's Health Fair. It's a great success and an opportunity to focus our efforts on women's health. We had about 150 attendees. 22 appointments were made. Unfortunately, only half of those folks showed up for those appointments, but I think it's still a step in the right direction and a vast improvement over last year. So thanks to our community partners, Aaron and others who came out to support the Women's Health Fair. Construction continues on our bus barn. Our framing is filling up. You can see the woodwork being done over on the side of the parking lot. And so we're a bit behind, but we've pushed our contractor to come up with some workforce for us and help us try to get things done by the end of July. So we'll see what happens. Hopefully the weather continues to cooperate. Yesterday, we had our white coat ceremony for our brand new class of interns, the MFMR class of 2028. So we have 9 new family medicine docs coming into RiverStone Health in the Montana Family Medicine Residency Program. Quite a large geographic swath that they will be representing. One medical student graduated from as far away as Odessa Medical University and graduated during the war from Ukraine. So we've got quite a few excited residents joining us. And then even more exciting are those residents who are graduating, third years going into regular independent practice. And so our outgoing residency class will have their graduation this Friday down at the Doubletree, and we'll celebrate that class as over 50% of them will be staying here in Montana. And 3 guaranteed, but probably 4 will be staying here at RiverStone Health upon graduation. So not too bad of a retention rate this year. The summer lunch program has started with SD2, and so SD2 and Sodexo are hosting their free summer lunch program for children, adolescents under 18 years of age. Adults are also able to eat, but kids under 18 are free. You can see the different locations across the county in SD2 schools. We'll have lunch available. Adults can also enjoy breakfast if it's or lunch is needed for $5.50. Breakfast will be available at certain community schools throughout the summer as well to ensure that folks have access to a reliable meal. Our Wellness on Wheels mobile unit will also be visiting those schools at certain times to provide school physicals, general access to care, and continue using the schools as a community hub. Our Healthy by Design Coalition's Gardeners Market kicked off on June 12th in South Park. It'll be there this afternoon and every Thursday from 4 to 6 from now until October. And so if you're in the need for fresh produce or some great handmade goods, stop down to South Park and stop into the Gardeners Market on a Thursday afternoon. In the behavioral health world, we have completed several additional interviews for our behavioral health systems improvement specialist role. So the search continues there, and we are going to continue to hopefully hire that role very soon, and then rebuild the coalition, formerly known as Substance Abuse Connect, into a more holistic behavioral health focused organization that'll focus on the whole continuum of behavioral health and crisis care. Steve, you've got your hand raised.
Yeah, it probably doesn't, but on the Sodexo, because of what's happening with School District 2 and changing of the vendor to Chartwell's, does that impact your program at all?
Well, that's their program, so that's a good question. Anybody know?
No, it does not.
No, it does not. Melissa said.
Kicks in at the beginning of the.
So the new contract is at the beginning of next school year, not over the summer.
Okay. Just ask.
Thank you. No, thanks, Steve. Good question. So then we continue. Vaccination clinics are currently being scheduled at community centers, senior centers, other locations across the county. We had 2 great clinics at the Adult Resource Alliance and their new organization of partnership. And so those vaccination clinics will continue for folks. Public health emergency preparedness is still planning an exercise, a point of distribution for medical countermeasures from the SNS or Strategic National Stockpile. We are looking at venues, and maybe Mark, you and I could talk offline about utilization of the pavilion at Metro. So we'll talk about that later. As far as public health officer updates, as of June 19th, so Kurt wrote this report last week, so we can get it out. A total of 1,200 confirmed measles cases were reported across 36 jurisdictions in the country. So that's national data. 23 outbreaks reported so far. Almost 90% of confirmed cases were outbreak associated. For comparison, there were not as many outbreaks nor as outbreak associated cases last year. We're currently up to 22 cases. That may have changed, but I don't think so. But you can find out now for yourself through the DPHHS Measles in Montana dashboard. That's a tool out there. So you can see where the cases are, primarily in Gallatin County and a few in Hill County. The most concerning cases that we have in our region are those in Gallatin County, where confirmed appears to have occurred, and the Hill County appears now to have their cases isolated and under control. The 2 reported cases that we had here in Yellowstone County residents were an adult and a child, and they were obtained during travel, international travel, and then resolved prior to their return to the county. However, they knew that they were sick. When they returned home, they got a blood test, and that's how we confirmed that while they were traveling, they indeed had measles. There was no transmission expected or confirmed from those cases. And then additionally, we had 1 individual travel from out of state, from the Midwest, traveling through the Billings Airport and several other states in our region over Memorial Day. And so that triggered the press release about the airport incident, where there was an individual who sat in the airport for many, many hours. When they got there early for their flight, and two, their flight was delayed due to summer storms in Denver. I think we're all familiar with that. And so there was concern that because that individual could have been infectious for so long at the airport, that we may have seen additional cases locally. And we have not received any reports of illness as a result. There was concern with the city of Billings and the airport management about why we would share that, why we would put a press release out. And I clarified with our city administrator and airport leadership that it was for contact tracing purposes and public awareness, that we wanted to know that if anyone got ill over the past couple weeks, there potentially could have been exposed to measles. Therefore, they could have potentially contracted measles. And we just wanted to know if any staff or travelers got sick as a result of this exposure. So fortunately not. Any other questions, comments, or concerns about the report this morning?
I'm curious with them being or concerned about reporting. I mean, do they share reasons why they're concerned about that? It seems to me it makes sense to.
It's the same concern we talk about around the table before we release the press release is, what negative pushback is the public going to give us this time? Because we're educating them and we're informing them in a timely manner, right? There were questions about, well, why did you tell us 2 weeks after Memorial Day? And so we had to go out and explain that. The traveler was from out of state, from another jurisdiction. They had to do their contact tracing and find out where the individual was. They had to test them for measles. They had to do all those things. And once they confirmed that, they then reported to the CDC, which reported to DPHHS, which reported to us, and all of that resulted in further delays. And so could we improve our timeliness? Certainly. In a world where funding and legislation is making that more and more impossible every day, good luck. But that's why it's important to fund public health. That's why it's important to support the CDC's reform and efforts to improve the timeliness of reporting so that we can share that information more readily.
So it's more of a timeliness issue than the fact that it was shared.
Correct.
Okay.
Correct. The city had questions about, well, why are we raising the alarm on this? And I made it very clear, we're not trying to be alarmist. We're trying to educate the public and be transparent. And we want to know if people got sick, period. It was purely an effort to do some contact tracing and make sure that no additional cases of measles went undetected.
Thank you.
You bet.
Couple comments, John. The retention of the graduating class, the residency. Keep four of those docs here. It's just rock star.
Yeah.
The clinical impact, I'm sure, is huge, but the bean counters can see that kind of stuff in the financial statements every month also. Wish Megan was here to hear that, but I think that's wonderful.
Yeah. And then the team, the faculty, both here and at both hospitals, and Dr. Brand's leadership have just been tremendous in focusing on how do we recruit and retain the right physicians for our program.
Cool. And I embellish John's comments about the golf tournament. It was my first time involved, and I'd encourage anybody who has a time or interest to get out there in the coming years. What impressed me most, I think, one of the cool things about RiverStone are the volunteers. There's a bunch of them around this table that have some kind of commitment to the organization. If you see them at the tournament, some of these people have been working that tournament for 30 years. Just have some emotional tie. They've been employed here. You know, the teams were, one day I was a hole monitor, so watching for a hole in one on the par three and keep Steve from coming and he won another prize. And, you know, a lot of the students that came up to the green, they would have often some tie to RiverStone, that parents or grandparents had received care here, often through hospice. But it was a good day, a good couple of days. That's it.
And I didn't share, I'll share for maybe with the executive committee, the photo that I had the opportunity to take of Jim taking his whole monitor very seriously.
I didn't have a beer in my hand that.
No,
Okay, good. Anything else, John?
that's it.
Comments or questions, others for John? Megan isn't here this morning, I don't believe. Back there, Megan, I haven't noticed you.
No, Megan's on travel this week at the conference in New Orleans on, which one is this?
It's a child abuse conference. It's a CAC.
Conference.
Yeah.
Yep. So going to learn some best practices. I'll just try to highlight some additional things out of the CMO report. We talked about our residents and providers who are staying with us. So we'll have, with the graduates of the residency program, we will have 5 new physicians starting here at RiverStone Health this fall. So been some great efforts to recruit and retain providers. We have a couple providers who will be transitioning out, however. So Dr. Fonken will be leaving to head to Washington, and Dr. Lee will be moving out of state this summer. However, she's going to continue working for us as the medical director of the Ryan White program and continue offering HIV services at telehealth. So we'll continue to retain her. She just won't be physically located here at RiverStone Health. We also have hired a dental resident. So we'll have a new dental resident coming to us very shortly. And that will happen outside of the typical NYU Langone program batch. So that's good news for our dental program. We continue to grow our partnership with SD2. And so we're going to be hiring another school-based therapist. We'll be traveling with the WOW and outside of the mobile unit to offer youth counseling services. And so that's been a great partnership. Continuing on the Project Aware program, advancing wellness and resiliency in education, which was a statewide SAMHSA grant-funded project. While there's been some funding changes there, it's been so successful that together with SD2, we're going to maintain some of those initiatives, grow our staff position and our LCSW role, and continue to serve students across SD2. So we found some additional grants and other opportunities to make that program sustainable. There was a question about scheduling the mobile unit, our WOW vehicle. It has been out on the road and very successful so far. It's been out to Elder Grove, to West, to Skyview, the Career Center, down to Blue Creek, Riverside, Lewis and Clark. And this week we went up to Broadview. And so it's been great to get out into communities and get that unit scheduled. Anybody and everybody can go to riverstonehealth.org /WOW and see the schedule for Wellness on Wheels. And so it's readily available out there so that you'll know when it's coming to your neighborhood. And there's been more communication with Northern Broadcasting and our ability to tell our radio partners that broadcast down into some of these rural communities, where and when we're going to be out there.
What's the staffing typically on that? Wow.
So we have 2 to 3, Eric?
Right now, it's been a medical provider and a couple accompanying clinical support staff. We just hired a PRN dentist to help free up one of our dentists to be able to go out on the mobile unit. So it came to us with the chairs that we didn't order, and the chairs are now in. So as soon as those chairs get installed, we will have the capacity to do both dental and medical in both exam rooms on the trailer.
In the ECW electronic health record world, we're currently in the last stage of piloting and implementing our ability to do telehealth visits directly through our EHR. And so we hope to share some more news on that with the boards in the coming days or months. And that is the CMO report.
Spencer.
Well, good morning, everyone. I'll report on the financial position of the financial reports for the month of April. So a couple of things we'll go over at the end. We'll ask for your acceptance of the April 2025 RSH financial statements, and as well as approval on the fiscal year 2026 RSH final budget proposal, our public health bill allocation, and the proposed combined capital budgets. As you all recall, I'm sure our fiscal year begins July 1st, so the end of the fiscal year 2025 isn't quickly approaching. But if we start off with the balance sheet, it's on page 25. If you're looking at it electronically, see that the organization continues to perform well. In the financial world, a boring report is a great report, and that's what we have this time. Everything, the machine continues to turn along. From a cash perspective, which has been a point of emphasis this year, our total cash approximated 12.9 million. Above that, 10 million is unrestricted. So that's an improvement of almost 5 million over the fiscal year or last fiscal year end. So that's been very positive. That equates to essentially 59 days of cash on hand, which has been the metric that we've been monitoring throughout the course of this year. So, if we flip over to the statement of revenue and expenditures during the course of April, the organization had net revenue of close to 800,000. That's a positive variance of 817,000 over our budget for the year. So overall, a good month. If you look at that year to date, patient services revenue accounted for $235,000 positive variance for the month of April, which is fantastic. And year to date, that patient services, which is our Medicare, Medicaid, insurance, and self-pay, was $1.1 million. So that's been a primary driver of our variance for year to date, which is 4.6 million. The key drivers of that. The other areas that we, from a financial perspective, see positive. It's been the wage and benefits expenses with $135,000 under budget for April, and then year to date that's been 1.6 million. So you can see those two add up to a considerable portion of that overall net positive revenue.
And is that vacancy savings?
And part of that's vacancy savings. Yeah. Shannon, what percentage is vacancy savings?
Yeah, so it's a combination of vacancy savings and how we budget for this fiscal year. So for fiscal year 25, we budgeted all FTEs in at their full accrual. So like they weren't using any of their vacation and sick leave.
Oh.
And then, obviously one, just to be a little bit conservative, and two, it's hard to predict when people are going to use that leave throughout the year. approach for fiscal year 26. And so we budgeted people in at our attendance policy. So 94% attendance. So just being a little less conservative in that approach for our fiscal year 26 budget. So we won't see that huge variance in the next year's budget.
I think the other thing is this, Shanna points this out in her financial report. So of the $4.4 million year-to-date net revenue, the 340B pharmacy program accounts for approximately $2 million. So that's so our pharmacy continues to be a significant contributor to our overall net revenue. Any questions? That's kind of a quick report on the financial reports, but just on the April reports. Any questions for Shanna or myself? Yeah.
No, I think it just looks good. I'm still thinking my head in awe how quickly it is recovering.
It was boring report. So we strive for boring. So the next thing that we'll just touch on is the fiscal year 2026 financial budget. Danny can speak probably more specifically to the specifics of that. But actually, why don't I let you do that?
Okay.
Stumble through it.
Sounds good. So touched a little bit on it last meeting, but for our fiscal year 26 budget, we did remain third in our approach. Again, we want to continue that priority of increasing days cash on hand. And a few months ago, the board gave us direction to increase 20 days cash on hand over the next 2 fiscal years. However, that looks 10 days and 10 days or whatever mix of that. In my head, it's 10 days each year. And so obviously factoring that into our budget approach for fiscal year 26. As far as challenges and opportunities within the next fiscal year's budget, the biggest thing that we did for this next fiscal year was add in staff increases. And so $968,000 in staff increases, close to $1 million in this coming fiscal year, which is an important thing for us organizationally. It's the thing that's coming up in all of our staff surveys. And again, last fiscal year, we did not have a staff increase. So that was definitely a priority in this fiscal year. Some of the things we're facing as challenges have to do with some of the increasing expenses, increasing our health insurance premiums, as well as a decrease in our 340B reimbursement. That's going to come to the tune of about $700,000 a year, and that decrease in reimbursement. That starts in January of 26, so obviously I only recognize half of that in this coming fiscal year. So about a $328,000 decrease in our 340B revenue, which as Spencer touched on briefly in the April financial report. That's a significant source of revenue to us and bringing in about $2 million of our bottom line right now. And so we factored in the decrease in that 340B revenue. And then other things we're facing are the loss of our COVID funding, and that equates to about $1 million organizationally in our fiscal year 25 financials. And so just managing and monitoring around those things in the budget for fiscal year 26. We have seen a little bit of an uptick in our overhead per FTE. Last fiscal year was a real priority for us to bring that down. In fiscal year 24, it neared about 22,500 per FTE. We got that down this last fiscal year to about 17,500 per FTE, which was significant, but it's crept back up a little bit to 19,200 per FTE. So just, I mean, it feels manageable, but just something that we continue to manage and monitor around the organization. So fiscal year 26 proposed budget has a bottom line of $585, about as close to break even as we could get it. Really, I think based on that current budget, we're expected to add cash on hand about 5.7 days. And so that's really just due to some of the non-cash expenses, the depreciation that's included in the budget. And so if all goes as planned, we should be able to meet the metric of 10 days, I believe, just based on what we have in this year's budget.
So on salary increases, what did we give for a general percentage?
So this was the first year we've done something other than just a general across the board percentage organizationally. And so really just looked at trying to get individuals moved more into the market. And so we took our wage table and aged it 5% as it relates to all the classifications within the organization. And then just tried to also look at some of the classifications that haven't received increases in the previous year. So a few years ago, we really concentrated on levels 1 through 9 within our classifications and put quite a bit of money, I think $500,000 into increases for those levels, with the promise or guarantee that we would hit the next classification levels in the coming year as well. Obviously, last year we come on the heel of a reduction in force with no staff increases. And so just looking at kind of prioritizing those higher level classifications as well as getting everybody across the board increases. So really the minimum increase for staff was $1.25 an hour. I mean, obviously there's some caveats in that with the new hires and some of the positions that received equity adjustments within the last fiscal year. But it was the first year that everybody didn't get the exact same percent increase.
And so is the idea to try to move everybody to at least midpoint of their band, if that's.
Yeah. I mean, we really tried that even with this increase. And so, yes, absolutely. And I think this next year really just concentrating on compensation within the organization, performance metrics, and just getting to a better place as far as the salaries go for the organization.
So you're working on your retaining employees.
Absolutely.
That's starting
Retention.
From
Yeah.
hiring and
All the
training.
fun. Yeah, it's like I said, one of the things that's standing out in all of our staff surveys, and rightfully so. And it's really concentrating on that and making it a priority this next fiscal year.
We gave 3% of the county.
Okay.
Which is basically CPI.
Yeah.
It's been traditionally about between 11 and 15% behind our other, employment competitors in the county. And so it's how do we make up that gap so we're not just constantly turning and burning?
Shannon, did you swag the delta that remains after you apply $1 million to rate to staff raises? If you wanted to do that comprehensively, what you did for the selected individuals, had you applied that comprehensively to the organization, what would the annual cost be?
I mean, I bet we could easily put a couple more million into it.
Okay.
I mean, easily.
Good. Thanks.
I think that, from my vantage point, the staff's taken a relatively conservative approach to revenue growth and to expenses, just the forecasting of expenses. It seems like they've itemized the budget to the point they're looking at every individual expense area. It's generalizing. So I think they've done a really good job of putting a good solid budget together. I think you can look at the overall forecasted revenues and we're not promising, massive revenue gains this year. I think we're approaching it very reasonably. So I think that's important also to acknowledge. So I think that's all I had. Just unless there are other questions. So thanks, Shannon, for his input.
Okay, so we get a motion to accept.
So moved.
Second,
Second.
on favor?
Aye.
So moved, motion to approve the financial statement.
So moved.
Second.
Second,
I was second.
sorry. All in favor?
Aye.
So moved. Motion to accept the operating budget.
So moved.
Second.
All in favor?
Aye.
Motion to approve the capital budget.
So moved.
Second.
All in favor?
Aye.
Approval of the motion to approve the mill levy allocation.
So moved.
Second.
All in favor?
Aye.
Thanks. All right. Dr. Campy has retired. Yeah,
Quick comment. Mark, you had a comment about retention and salaries and how it worked with retention. We've made a strong effort over the last decade or more in regards to staff retention, and it's outstanding compared to peers. John, maybe you could come up with some specific numbers, but you made a tremendous effort at staff retention. But do we have specific numbers that pop off your head?
I do, and these are from last month. The industry average turnover annually in healthcare is about 35%. And month to month, it's between 3 to 5%. Our industry average for the last 4 years has not gone over 14%, and it's been on average about 10 to 11%. So month to month this year, and even last year with all of the struggles we had, the reductions in force, we never had a month over 2.4%. And this year, we've been about 1 to 1.5%.
And so that includes doctors who are progressing in their careers and they leave to go into private practice, say, which is something you can never, I mean, that's a segment you're never going to be able to retain.
Right. Other questions or comments about the finance committee report? Michael?
Okay, so the the Safety and Quality Committee focused on public health and in particular data. And there's really two main parts to the discussion. The first had to do with kinds of information that is being compiled, put together into, say, our dashboard. That, by the way, if you haven't clicked on that link to the dashboard, I would encourage you to do that. That basically shows information basically designed for our public, really, to be able to see the kinds of things that the public health department is monitoring. Partly to focus on building trust, that people can see that the community can see that in fact these are the kinds of things that we're doing and why we're doing them. The website is interactive. It looks at a rolling 12-month time period, not just simply a year. It's like 2024 or 2025, get a whole year. Turns out something I didn't know is that individuals can actually request of the epidemiologist request information. So it's kind of interesting. I don't know how many people from the public actually do that, but the problem with our dashboard is that it's information that is old, relatively old. So you're really looking backwards in a sense. And so in order to look at this information in a different way, we learned a new term, which is syndromic surveillance. So syndromic surveillance means active or active real-time data. And in fact, there is a data system called Essence, which was developed, I think, in the VA system I don't know, 10, 15.
DOD, yeah.
The DOD,
the military medical system. Yep.
And what this allows is for nearly real-time information to be looked at. So, for example, somebody shows up in the emergency room and they're there for some sort of a GI problem. That information is fed into the system pretty much real time, even before diagnosis is confirmed, and then that information, once confirmed, also gets put into that system. And so the strength or the power of that information is that now you can be alerted when all of a sudden there's this rise in maybe there's an outbreak of cholera in buildings, or whatever it happens to be, so that it gives us the opportunity to react more quickly. So currently, and then this, I think every state now has this system, and we've been using it. The state has been using this now not very long, about a year or so or less. And the information we get really that we have access to is really limited to Yellowstone County. Currently, the emergency rooms at both St. Vincent and at the Billings Clinic contribute to the system. Billings Clinic inpatient contributes to the system, but St. Vincent does not yet, I think. So they're a little bit behind on that. I don't think that RiverStone contributes to that, or do we? Or would we?
We do. We do.
We do.
Oh,
No, we.
only in hospitals.
Oh, we don't.
So I don't know.
We get the data, right?
Yeah, I don't know if we're supposed to.
The way that Essence is connected to emergency rooms,
Yeah.
urgent cares, those sorts of things.
I think that's
through
more-
electronic health record.
I would think that'd be more important than the inpatient side anyway. So, I mean, I don't think we're missing a lot. I don't think. Anyway, so basically, we're looking at information, both retrospective information and in real time, perhaps even there's something that we can act on. So that was actually, I thought, one of the more interesting meetings that we've had in a while, but that's what we're about. So that's happening now.
Any questions or comments?
Except for the votes.
Saying me too.
Says board action.
Oh.
Okay. All in favor?
You gotta take action.
Opposed? Hearing none. Your report is accepted. Well, I will turn the, no. Yeah, we'll turn the tables here now on Brent. Public health policy, right?
Well, we discussed two topics. The first was the status of immunizations in daycare and school, and we're in actually pretty good shape on that, despite the recent discussions nationally. And they're able to protect their children. Then we spent quite a bit of time, and we have the last few months on the area of Cava and Creighton. And you may have seen around town the increasing availability of products, both in specific locations that Cava bars, this type of thing. Also in some of the stores, you'll see cans of Kratom. So we thought it was time to have the entire board more fully aware of the issues involved in this. And we've invited Melissa Henderson to be a guest speaker at this board meeting. And I think we're doing that now, right? And not.
We are, before we do that, if you would like me to share an update on the big beautiful bill and impacts to Medicaid and conversations we were having. So we had a couple conversations on the status of the big beautiful bill, and now that it is in the Senate, what could it do to Medicaid in Montana, and what might it do to WIC and SNAP benefits across the country? So I just wanted to update the board on a few changes this week, and I'm going to go back after the board meeting today and spend a lot of time digging into what its current state is today, because it changes every single day, and I highly doubt that DC will get their act together to actually vote before this weekend's recess. I've been surprised before, but we'll see. One of my favorite senators to have worked with over my career is Senator Tillis out of North Carolina. And he has been putting up a fight lately on the drastic changes to Medicaid and state funding due to provider taxes. And so he's been ringing the bell on provider tax changes. While those won't impact us here in Montana, it's been a good conversation starter for folks on both sides of the aisle. This week, however, changes to the FMAP have re-entered the conversation. And so the FMAP is that federal matching percentage that DC gives the state. And so that's anywhere between 80-20 to 90-10 to match the amount of money that the feds give us to support Medicaid and Medicaid expansion. And so now that FMAP, federal match, has re-entered the conversation, that raises alarm bells for us in the state of Montana, because we are one of the 12 trigger states that if any changes to the FMAP occur, it won't matter that we just authorize Medicaid expansion in our state legislature. DC will tell our legislature, go pound sand, and because we have that trigger in the Health Act, and force a special session to occur if any FMAP changes are carried forward into the final legislation. So that's something we're watching closely. The bill in its current form, and again, these are just the facts, folks. The bill in its current form would have about 11 million people across the country losing healthcare coverage. The Senate's version has gone further than the House version with the provider tax issues. And however, it doesn't impact our hospital utilization fund, which is our Montana provider tax that our legislature has created. But our concern remains that people who should be covered and who are eligible to be covered will still lose care and access to insurance either on the ACA exchange or through Medicaid. And so we could see double-digit uninsured rates return to Montana. That's going to continue to put pressure on rural hospitals, on healthcare costs, on uncompensated care for our hospitals, et cetera. The current bill would cut about $800 billion across 10 years in the country. Again, 11 million fewer people would be enrolled in Medicaid, and it would potentially lead to increased food insecurity, making it difficult for folks to sustain their health. And so 31,000 of those 11 million would be here in Montana. So 31,000 Montanans could lose coverage with the changes in eligibility and enrollment processes. That includes 27,000 adults and 4,000 plus children with disabilities and elderly Montanans. We know that state data already shows over 93% of Montanans are either working in school or permanently disabled, being a permanent caregiver. And so we will accept work requirements that are written into the HELP Act already. And we've had those conversations with our legislature to say, hey, support the work requirements that are already in the HELP Act. We already have them written. We can execute them with DPHHS and support Montanans. What we don't want is some one-size-fits-all work requirement coming to us from Congress and DC and saying, thou shalt do it this way, when we already have some of the mechanisms in place. The new dietary guidelines coming out of MAHA are emphasizing reducing childhood obesity, which disproportionately affects lower income families. Those same families have the highest rates of food insecurity. And so the new bill drastically cuts SNAP and WIC. The SNAP and WIC are not luxuries. They are not entitlements. They are some of the only ways that these families can afford milk, eggs, whole grains, fresh produce, use their benefits at our gardeners market and farmers markets across the state, supporting local agriculture and the industry. And so the ag community and the healthcare community are pushing back equally as hard against some of the SNAP and WIC changes because they have the potential to drastically impact the livelihood of our farmers and our ag community. It is a very interesting tightrope to walk this line and say, well, we're supporting MAHA. However, we're cutting and we're creating greater food insecurity. And so we're not going to have those great impacts that we want to have in food insecurity, obesity, diabetes, and other issues that MAHA is focused on. This WIC and SNAP change is just going to lead to sicker women, sicker children, and sicker babies. And under that proposal, breastfeeding mothers would see monthly benefits plummet from $54 to just $13, and young children's benefits would drop from $27 to $10. With the rising cost of nutritious food, I don't see where that makes any sense. So that's the update on where we are currently with the health impacts to the One Big Beautiful Bill. And this week, hopefully by the end of the week, we'll have some more clarity on what the Senate is actually going to vote on. And then we can start this conversation of reconciliation between the Senate and the House and try to get some common sense legislation through. Nothing going on.
Is there a message that we could leave with senators and congressmen?
Yes, and I think it's a more respectable message than some of the things that are being shared out there across the country by certain partisan political groups. I think we have the ability to share the message that what we need support for is what we can support in Montana, not a one-size-fits-all approach to work requirements, not touching the FMAP, not touching the provider tax, and helping support rural frontier residents and healthcare institutions. We can say that with the changes as is, rural frontier critical access and emergency hospitals in the state of Montana will very likely close. Not a single one of our delegates want that to happen, but that's the truth.
Can you quickly script something, have Terry send it out to the board? Numbers we should call and leave a message?
We actually we'll make it even easier, and all you're gonna have to do is click a link and fill in your personal information. So awesome, we'll do that.
Great. Thanks.
Thank you. All right, Melissa.
Brent, are we ready then for Melissa?
I think we are.
Yeah.
Eric's gonna help.
Melissa.
Eric and I are gonna tag team because we just both love talking about it.
Ready for Melissa. I'm not ready.
Get some more coffee for him.
And Eric, I'll share the slide deck. It's
Okay.
here, right?
And my cough isn't contagious. It's a residual daycare cough, so. I see.
So, disclosure, you guys are getting the B team. Usually we have a dynamic duo of a health promotion specialist and one of our EH folks do a similar presentation to this, and they are our boots on the ground experts on this stuff. But if you have any questions that we can't answer, we'll take them to get back to you. So you want to go ahead to the third slide.
Oh, I will, as soon as I figure out how to do it correctly.
So basically what we're going to talk about today is kind of a little bit of an overview of, what is a designer drug? How our conversations about CAVA and Kratom interface with the designer drug conversation, what we do for existing regulation, what's within the scope of public health and what currently isn't, and some opportunities for action that we have moving forward. So designer drugs are either drugs that are manufactured in a lab to mimic the effects of other drugs, or in some cases, they're derivatives of the drugs where the potency has been drastically decreased over what you would find if you had the natural substance. And so here are some examples. You find a lot of stuff that is kind of building off of the marijuana. So you'll see these in stores called K2, Spice, Delta 8, synthetic opioids, some, made for legitimate medical purposes that get diverted, and some that are manufactured specifically for the purpose of use in illicit drugs. LSD is one, meth, MDA, ecstasy, bath salts, all those are examples of designer drugs that are developed in a lab to mimic the effects of other drugs out there. And often it's done to skirt regulation. So a lot of regulation about, say, marijuana defines what marijuana is, but these folks will develop a synthetic in a lab that mimics what marijuana does, but has different chemical components specifically to skirt legislation that's in place to prohibit the sale of some things, right?
And to skirt the testing, right?
Yeah.
So drug tests haven't caught up to a lot of these products as well.
Yeah. So two of these emerging designer drugs, which also have a natural component and a synthetic component that we're seeing coming into our area rapidly, are kava and kratom. What they have in common is that they both start off as natural leaf substances, one from the South Pacific Islands and one from South Asia, that have their roots in ceremonial purposes. When used in their natural state, there are psychoactive effects, but they're not as bad as what we're seeing with some of the synthetics that are coming out that have very high concentrated levels of the psychoactive ingredients in these things. So one is kava. It's traditionally used for ceremonial purposes. When it's manufactured into things like teas, powders, tablets, sodas, concentrates, ready-to-drink beverages, the potency goes way up over the natural leaf that can be brewed as a tea. It's classified as a depressant. Here are some of the kind of side effects of taking kava. One distinguishing factor between kava and kratom, kava is approved as a supplement by the FDA.
I'll get into the nuance of that in a little bit.
And that influences how we react to it being sold in our community in established food settings. So then we get to kratom. Similar in that it starts out as a leaf. It's also now sold in powders, tablets, concentrates, ready-to-drink beverages. Sometimes kava and kratom are mixed together in beverages. Sometimes they're sold separately. Here's some of the side effects. And some of these are linked to the potency. Some of the stuff we're hearing from our physicians in town, from ER docs, is that the synthetic or manipulated kratom products out there that are increasing the potency of it are having severe addictive effects, are needing to be, the symptoms are needing to be reversed with Narcan, and overdoses are happening from it. We're giving you the quick version here. So the difference between kava and kratom regulatory wise is kratom is not recognized as a supplement, an approved supplement, additive, or something that can be sold in restaurants by the FDA. So kratom lives in this regulatory of a gray zone where the FDA has said it's not legal to sell it in licensed food establishments, but it's not illegal to sell in other areas. It's just not an approved thing to add into food or to use or to market as a supplement. All right. So Melissa can come back to the legality of kratom. There are areas around the country that are starting to regulate kratom, either at the state level, the city, county, different levels of jurisdictions are starting to regulate kratom. Common sales locations in our town are smoke shops, gas stations, bars. The kava houses are selling kratom. That's the most common places.
Yeah. And there have been several news articles out, excuse me. I have an 18-month-old that's going through her first year of daycare. So I'm getting all of the daycare exposures. The AP just put out a story last week, really dubbing kratom gas station heroin. That's what it is. It's having this addictive potential. The problem that we're seeing and we're hearing from our physicians, like our medical director, Chris Baumert, is it's not one demographic that's seeking kratom use. It's, people like me that maybe have a little hip pain and are scared. I've got the memo that opioids are bad. That's scary. Don't ask your provider about pain medication. Instead, they're turning to these alternative supplements that are being marketed as all natural and then getting admitted to the hospital for withdrawal symptoms, because at about 6 months, we're seeing that people can get addicted to this to the same degree that they would be on opioids. The nice thing with opioids is they're prescribed, they're followed, providers know that people are taking them and can have that conversation. What we're seeing and hearing is people aren't even reporting kratom to their providers on their med list because they don't think of it as something that would be causing bodily harm, causing withdrawal, interacting with other symptoms. And there's this misconception that overdoses that are occurring with kratom are happening with other drugs, that it's polydrug use, but that's simply not true. Colorado just passed a law called Daniel's Law, pushing for regulation of kratom because a 38-year-old man, Daniel, died simply by consuming kratom. That's all he had in his system, and maybe a little Benadryl. But who among us, when you're not feeling well, takes a little Benadryl and then, tries to do that? So in terms of actual regulation, we'll jump back to where I was. Sorry.
All right.
We as the health department, through Montana code, we license several establishments in our community. The largest program that we have is licensed food establishment, right? We go into any establishment that wants to sell food or beverage to consumers. We check for risk factors, things like that. And we make sure that they're adhering to the Montana food code. So next slide. So what they do is when a business wants to open to sell food, they come to us, they submit a plan review, they tell us what's going to be on their menu, what processes they're going to use, what equipment they're going to use. If they want to do something a little bit out of the box, they may have to get some additional approvals from our office. But this is them saying, this is exactly what my game plan is. We first and foremost review that against the food code. Are they selling products that are authorized in the state of Montana? Are they preparing products in a way that Montana has agreed to? Then we go to the establishment before they open and say, okay, you're doing what you said you did. Great. And then as they're licensed, we do unannounced inspections and then follow-up inspections as needed. And depending on the level of risk based on their menu, we'll go back multiple times throughout the year unexpectedly or unannounced. So the food code is really interesting. The US has what's called the FDA's model food code. And it's really a template for what best practices are based on the science behind foodborne illness. And then each state takes it upon themselves to adopt the food code and then any modifications they want to make. So in Montana, we are working under the 2013 model food code. And then when our legislature passes rules around, like a big issue this year was lab grown meat, that becomes an addendum to our state food code. So anytime an establishment wants to go beyond what's written in the food code and the rules, they actually have to get state level action to create those exceptions. It sets minimum food standards for anyone that's serving food. And then, as I mentioned, the whole point is to protect the public. Next slide. Our job, again, by code, is to enforce that food code. Next. So the big thing that we look for when we get a menu submitted to us is that the food falls within the approved ingredients. There are 3 different categories that ingredients can fall under. Conventional foods, so these are just kind of traditional foods you would expect in a menu. Approved food additives, so these are items that are being added to food and then served to the public. One that we've kind of gotten hiccups on, a local restaurant wanted to serve charcoal as part of their food product. Charcoal's not approved in the food code, so we had to go a little bit back and forth there. And then foods also need to be generally recognized as safe. We call this the GRAS list or the GROS list, depending on how you pronounce it. These are things that have to have evidence that they are safe. So Kava and kratom, neither of them are approved as additives. They can't be part of a food product because they don't meet those requirements. However, kava has been approved as a supplement. And so if you came to my restaurant, I could say, here is a cup of tea, and then here's a kava ball that I'm selling as a supplement. If you want to mix them together, that's your business. I cannot mix them together because if I, as the food operator, mix them, it becomes an additive, not a supplement. Anytime you're using an approved supplement, it has to come from an approved source. And we're going to talk about that in a minute. This is what they look like, the little kava balls. This is often what we see in our establishments are these wholesale bags of these products. There's no label of where it came from, but it does say not for retail use, meaning it hasn't been approved for giving to an actual consumer. Next. These are also images from our local establishments during inspections of the powders that they're using in these products.
Just a fun little aside, if
Yeah.
you want to go back to that one. So the two people I said who are go-to for this presentation did it at a law enforcement conference. And the cops were like appalled. They were like, if we went into a place and saw those bags, we would confiscate them now and ask questions later. And then we had to get into a whole conversation about the difference between public health and police enforcement.
Right.
But just to give you like a sense of how the law enforcement folks reacted when they saw this, they said, if we saw those unmarked bags someplace, we would take them.
Yeah. So a few things. So what's really difficult for us is we're rule followers in public health, right? We stay within the scope of our jurisdiction. We're trying to do the right thing and work with our operators to educate them on what's allowed, what's not allowed. But sometimes those rules feel a little bit arbitrary, right? Is it really that big of a difference if I'm saying, here, I'm going to sell these two things to you, but because your hands put them together, suddenly it's okay? It's hard to enforce that too, because that seems like a silly rule, but it's what the rule says. It's also really difficult because for us, we have to treat everyone equally, every business equally, and every product equally. We are way more freaked out as a public health department about kratom than we are kava. Kava has concerns, but kratom is what people are overdosing on. However, we have to enforce the food code equally. We can't pick and choose what we enforce. Similarly, we know that gas stations are more likely to sell those high potency 5-hour energy drinks that people are overdosing on, not necessarily the kava bars that are serving it as a quick beverage. I'm not saying that one is okay and the other isn't, but there is a different degree of severity. We have to enforce them equally. The other thing is because of this kind of gray level of legality, there's no standard research or recommendation. So part of the state legislature that we helped with this year, they were really seeking to regulate kava or to regulate kratom by requiring the sellers to include serving sizes and recommendations. And we had to keep saying, but there is no recommended serving size. You need that science, you need that piece. We need to understand this product to really get to it. It's also entirely honor system. And so people are buying growlers and kegs of this product, and it's a moneymaker. We are going to end up shutting down businesses if we really go after it, which we don't want to do. And so we really want to figure out how do we educate the consumer and require the sellers to educate the consumers on the products. Until this legislative session and this kind of bullseye on or magnifying glass on the issue, we know local establishments were marketing and selling to minors. Now they say they're not, but again, that's still honor system, right? If we popped in and did a check, would there be there, or would they be doing that? And then of course, we aren't there every single day, nor is it our job to be there every single day. But when we do our follow-ups or we receive complaints, we know that supplement pass-through is only happening occasionally, especially when we're there. We also know that some places just openly market that they sell kratom, even though we've told them they can't. If you drive around town, you'll see Mitra 9, ads on a lot of buildings, that's Kratom. That's technically not allowed to be marketed. Others may not market it, but we know they're selling it. And then we also know that some people will just move it or unplug the machine before we get there. Some people have just flat out told us, I'm not going to comply. Come for me. What can you really do as local public health? They know that we're a little on the weak side in terms of enforcement, and they know that there's ambiguity around these products. We do know that Kratom, again, is the moneymaker. These drinks are so expensive, especially when you buy them in bulk. It is the bottom line for a lot of businesses. And so we are cognizant of that fact that this does impact businesses. This is just a map of our license cancellation process. So we do the inspection. If they're not complying with something, we'll go back up to 3 times. And after 3 chances of coming into compliance, we'll actually request that the state cancel their license. Plenty of businesses operate without a license in this community. So because we are public health, we don't want to be overreactive, right? We know how that plays out. But what's really difficult is regulation often follows the prevalence of the product. Even at the state legislature, we were really adamant about trying to get our public health partners to help push for regulation of Kratom. But what we kept being told is this isn't really an issue for us. This is a Yellowstone County problem. That is what we find as Montana's biggest city. These issues come to us first, and then they look to us to be the model. And we're really struggling with that. There's also the fact that it's everywhere, that consumers see, well, if I saw it on the shelf, if my mom can buy it for her hip pain, it must be regulated. It must have gone through the vetting process. The consumer doesn't understand how many products can be on our shelves without any sort of regulation. The other challenge is that we want to educate our operators about the concerns. And when we can, and they really understand the risk, they're more willing to be educators. The problem is that kava and kratom do have harm reduction capabilities in those lower natural doses. And so they're believers of the health effects of it. They're not concerned about the risks. And so really where we're at is, at the end of the day, the feds need to get to the table and decide what they want to do with Kratom. They need to move forward with scheduling this product. As I mentioned, legislative action didn't quite come to fruition. I think it was too new of an issue, and the Kratom lobby was very much there in force, but we did see bipartisan support. We do know that at the state level, you can't manufacture Kratom. So there was talk about having a Kratom manufacturing establishment here in Yellowstone County. The state kiboshed that because that's against their rules. But when it comes to those licensed establishments, that falls on us at the county level. And as I've just described, it's pretty murky. And our staff are feeling a little bit hung out with no clear guidance. So that is why we've come to you. So at the Policy Development Committee, we've been talking about what can we do locally to protect our community and really move forward with this, not just for kava and kratom, but for whatever other designer drugs may come forward. Canna is another one that's coming forward that we're just starting to learn about. And so we are wondering what you all are thinking. And, you know, if you need time to think about this, obviously, I'm less familiar with your process. We are wondering about the feasibility of passing either a Board of Health rule, a local ordinance, a county ordinance, or a designer drug ban within our community. So it would allow those natural substances and their ceremonial forms to proceed. But in terms of the high potency, scary stuff that people are overdosing on, it would help create a ban on that within our community. So,
yeah.
Anything you'd like to add?
No, I think that covers it.
Okay.
I mean, we've gone through in your minutes, you kind of, the menu of different options to tackle this problem are attached to the minutes of the Policy Development Committee. And so we really did explore, like, you know, what would be least restrictive to most restrictive. We've been kind of batting this around for several months in that committee. And after a lot of discussion, we think that a ban on designer drugs in Yellowstone County would address the major problem that we're seeing. Our major concern is the synthetic high potency stuff. Address the issue of constantly emerging synthetics. It aligns with what other jurisdictions around the country are doing. We think we could get bipartisan support for this from our state delegation. Representative Nichols is the one that actually introduced the Kratom legislation in the Representatives, House of Representatives at the state. And also, we've been having conversations with the Kratom industry, and they've indicated that they would also support looking at synthetic drug bans because they're very interested in legitimizing their industry. They want most of the lobbyists in the Kratom industry are asking for them to be regulated. They want it because they want to be legit. And they feel like the synthetic stuff is what's giving them a bad rap. And frankly, it is. It's the irresponsible producers, marketers, sellers that are getting folks like that gentleman in Colorado in a bad way.
What was the cause of death of the guy in Colorado?
He was taking the little, like, so if one of the pictures you saw was the stuff that's getting sold in the gas stations, and they look like, you know what 5-hour energies are? They come in this little bottle like this and you chug them, and they're like supplements.
The
So
death certificate would say something killed him.
yes,
Cardiac arrest, something like that. Do you have any idea what
it was the combination of Benadryl and the Kratom shots.
So it's likely like respiratory suppression, things that you would see with opioid overdose.
Yeah.
Yeah, if I'm understanding your question
Yeah.
correctly.
When they do a random tox screen for yards, that automatically means
We're kind of figuring that out. Some law enforcement are saying, from the law enforcement side, they're saying we can add it. It's not on the standard list. And so I would imagine it's the same in ERs. It is definitely, we do OD map where we can look at data around what maybe led to an OD. We had several people after this presentation at that law enforcement symposium say, this is the first time I'm actually looking and considering Kratom.
Oh, Tim, to your point, the official cause of death on the death certificate for Daniel Breger was the combined toxic effects of nitrogenine and diphenhydramine or Benadryl.
Nitrogenines.
And nitrogenine is the alkaloid.
So from the committee, the consensus was more or less that we would suggest going ahead, our department working with the county attorney's office in developing regulation. We had several options, don't do nothing. And that's the opinion from the committee. But I have a question also. What's the incentive initially for someone to take one of these? In other words, is it because they have hip pain and they think it'll cure that, or they want some mood altering, or is it just like an energy drink, or is it just they think it tastes good like Pepsi, or?
So Kratom is an interesting drug. So at lower doses, it has a upper effect. At higher doses, it becomes a sedative. And so it's being marketed in a whole bunch of different ways. It's the natural alternative to opiates. So pain management. It's being marketed to people as a way to transition off of opiates. So a harm reduction strategy. It's being marketed as it's fun because you get a buzz out of it until you don't.
And that's what we're starting to hear from youth is people are saying, I'm pretty like our psychiatrist, Dr. Kelso had shared.
Yeah.
Youth are starting to see and market these little 5-hour energy drinks.
Any other questions or comments for Eric or Melissa?
You have to show an ID, you have to be gas stations, which is that.
It's completely unregulated.
It's kind of, again, the honor system. So they say that you do, but we know from a few people observing that a clerk might not know. So they don't really worry.
Michael?
Brent, how far away are we from your committee recommending to the board that we?
I think that's kind of one of the reasons we came here. I guess the decision is not made officially, that is, but can the committee do that?
The committee can recommend, and then
Right.
we can pursue it as a full board if the committee recommends it.
Well, the committee kind of has recommended, we took a straw poll and everyone was in favor of proceeding with, I mean, it's not going to happen in the next month anyway. It's going to have to work out details of what, and between the department and the county attorney. So it's pretty safe to go ahead with what we're talking about now.
Is the board generally in favor of the board that kind of working with the committee and the county to come up with an appropriate regulation? for the
Yeah.
county? Michael?
Yes. Jenna, do you have any comments from the county attorneys? Everybody's got a lot of things on their plate, but we've got to be progressive and think ahead. And this has gone on a little too long. And the Kratom one, looking at it as a toxicologist, the Kava, but the Kratom is a real problem. And we've always been charging ahead on these things that are meaningful to the community. Jenna?
Well, this, and we've had a lot of conversations about this. This regulation piece is exclusively in the county attorney's wheelhouse. So we really need to make sure that that conversation takes place with them sort of steering the ship. So I think having that conversation with them is the best way to go.
I would add that Steve Williams is aware that we're having this conversation this morning. We're chatting weekly about Kratom and Kava within our community, and so he is aware.
I think any regulation would not only apply to Kava and Kratom, but minor drugs generally, right?
Yes.
Just on the Gazette last week, there was discussion about some new, started with T with about 6 syllables. I don't know what.
And I would say,
That is coming also.
let's go, is that a
That's
vote
the
in
motion to
favor?
move
or-
ahead full steam,
Okay.
and it'll still take a year or more to get all, but let's, at this point, I make a motion that we move ahead as rapidly as reasonable and possible.
I would second that wholeheartedly.
So are we gonna have discussion here? This properly belongs at the legislature. This is design.
Yeah.
You know, this is not Yellowstone County. This is just I don't want to get sucked into something that we're the center of the vortex and we really only have control of Yellowstone County. The bigger issue is it needs to happen state.
Mark, what is the downside of us acting on this at the county level?
You know, it requires resources. And I'm sure there'll be a lawsuit, somebody's.
Yeah.
So, I mean, let's look at this just the way, look at the progression of how marijuana got legalized. Huge out-of-state money came in and, litigated it, took it through the election process, just because there's so much money in it. And I can see that that's just where this is.
Moved ahead on 15-foot rule, stand back from restaurants, indoor smoking in pavement. We took a lot of heat for that, and we took a lead. Waiting for the state to do something. I'm sorry, the politics are such these days that it takes forever. I'd rather take a progressive lead, and I hate to use that word, but I'd advocate for taking a leadership role, and maybe that could move the state ahead, maybe not.
Well, you're
But we
behind
can do it
schedule at this,
locally.
we're behind schedule at this point. There's a motion for you guys to proceed, all in favor of that.
Is there a second?
And I would just say, and there was a second, and with the purpose of discussion and conversation, the only thing that the Board of Health is directing staff and I do as health officer is to proceed with proposing action to the county attorney, to our county commissioners, to the council, to the state legislature, to continue acting and taking action.
And reasonably was part of
and
my
moving forward, right?
motion to do it reasonably.
With this reasonably. So I think the motion on the table is to direct staff and the health officer to move forward in a reasonable fashion, to work with the county, to work with the state and others.
The city.
And the city, to try to come up with some reasonable approach to managing this kratom problem.
And like Melissa said too, eventually it should be the federal thing too, so.
So could we get a vote, all in favor of the motion that John described? Please say
Aye.
those not in favor. Please say aye.
Aye.
Okay, the motion passes. Steve?
Oh, no, I was in favor of it.
Oh, thank you.
Can I get a motion to accept meeting notes?
So, second.
All in favor?
Aye.
Okay, quickly, governance met. The minutes are in your packet. We thank you all for responding to our surveys, our many surveys, trying to figure out if we have deficiencies at board level in our membership and our approach. The results of the last survey summarized here. Governance will meet next in August and choose among the where we might have constructive activity. If you have a suggestion for the committee, please let Carrie or another committee member know. And could I get a motion to accept the meeting notes?
So moved.
Second? All in favor?
Aye.
Thank you. Executive committee is meeting, trying to wrap up John's evaluation. After 14 years on the board, Steve pointed out to me, don't we need to work with CHC on this? And Gary confirmed that for me, so I'm now working with CHC. We will try to wrap it up by August and have it back to you for your approval.
And I think to say that the CHD discussions.
Good. I'm talking with the vice chair right now. Can I get a motion to accept the notes?
So moved.
Second,
Second.
all in favor?
Aye.
It's accepted. There is no old business that I'm aware of, and if there is, don't be aware of it. Someone from the EPA, I think, Roger Guggenheim, if I said that correctly, is here.
You said it good enough.
Not the first time it's been butchered, right?
Actually not.
Okay.
And I have some esteemed colleagues here. Do you want us to get up front or can we talk here? How would you want to do it? Because I don't have a presentation.
Come on up. I'll share the image of the site.
I'll let my colleagues introduce themselves.
Hi, I'm Dawn Nelson. I'm a state toxicologist with the Department of Resources. I'm Deanna Pabst. I'm with the DEQ and I'm the project manager of the Billings PC Superfund site.
All right, so the basis of the meeting is I'm what's called a remedial project manager at the Environmental Protection Agency, and I manage Superfund sites. So in Yellowstone County, there's 2 Superfund sites, the Lockwood Solvents groundwater plume site, and we also have the Billings PCE site. So I manage the Lockwood groundwater plume site, and one of the things that I worked with the board, and it was a little bit less than a decade ago, so I noticed there's a lot of fresh faces, but we put in a controlled groundwater area. So, and we submitted a petition to the Department of Natural Resources and Conservation, and RiverStone Health was the petitioner in support of the controlled groundwater area at Lockwood. So you're probably going to ask me a question, how can the board help? What we would like to do, but not now, it'll be in a couple of years, we would like to put a controlled groundwater area in here. So this is the Billings PCE plume site. Right here is the cemetery on Central Avenue, and here is Conoco. So you can see the extent of this plume going into downtown. So it's an 1,100 acre plume site. You have multiple dry cleaner releases. So, and dry cleaners use a chemical called tetrachloroethane. So when it gets into the environment, the chemical vaporizes. And what happens is that vapor accumulates underneath a structure and through preferential pathways, it can get into the indoor air. And depending on the levels, if people breathe it, they could have health effects. So very similar to radon. And the mitigation approach is to put radon mitigation systems into a structure in order to address the problem. So this is a plume, it's 1,100 acres. There's 4,200 structures that are within here. And we've defined it in various areas, what we call area A, B, and C. So area A, this is your worst release. And in area A, let me hold that. We are issuing what's called a proposed plan on Monday, which our alternative is to address the indoor air. And that was the basis for the meeting. We just wanted to give everybody a heads up. We have a public meeting set up for July 23rd at the Billings Library, 5:30 to 7:30. Does that sound right? We're going to send out a fact sheet right after July 4th to the public. So how the proposed plan works is we issue it to allow public comments. They have a minimum of 30 days to provide comments, but because we're issuing the proposed plan on Monday, but we're not having the public meeting for 3 weeks, in all likelihood, we're going to extend that public comment period. So that's the basis for this meeting, is just to give everybody a heads up that we're having that. So now let me talk about Area A. Area A has 700 residential structures and about 24 commercial. In our proposed plan, we are recommending every residential structure in here will be eligible for a radon mitigation system. We're not going to sample. It's because of the concentrations of the groundwater are high enough that we're seeing very high levels of those gases underneath the structures that we just feel, let's just put in the mitigation systems. It's actually going to be cheaper than it would be if we sample. Area B is your downtown kind of business corridor. We see sporadic levels underneath the home, underneath the commercial buildings, but it's not a lot. But because of the emphasis, there's a lot of properties that are being transferred in this area, a lot of development. We don't want Superfund to be hindering any type of development that's happening in downtown. So we're going to do a very robust outreach effort to try to get access to the Area B structures. In Area B, It's 700 residential and 700 commercial. Is that correct? And then area C, anybody who's in here is eligible for us to do indoor air sampling. And if the results either below the home or inside the home are at levels above our cleanup level, they'll be eligible for a mitigation system. And in here, there's 1,200 residential structures and another 700 commercial. So that's your universe of 4,200 structures. Our remedy is sampling, installation of mitigation systems, and then we call them institutional controls, but they're basically administrative controls. We'll work with the city of Billings. Like in this area, if somebody changes land use from commercial to residential, there's going to be an ordinance in place that they would have to put a mitigation system in. If they, like, there's a lot of instances where somebody may raise an old building and build a new one. In that instance, they would be required to put a mitigation system. And then the other thing that the city wanted, and Brianna and I are in agreement, is that we want to have a mechanism in place because there's a lot of rental units in here. We want a mechanism in place that if somebody were to enter into a lease to rent property, that they're aware of the health concerns. So we want to work with the city of Billings on that. The other thing, and Dawn, I wanted to kind of let you talk about your role in doing a health consultation, if you don't mind.
Yeah, so my team is conducting what we call public health assessment or a health consultation. And we do this in cooperation with the Agency for Toxic Substances and Disease Registry, or ATSDR. They're a federal agency under HHS. And under Superfund law, ATSDR is mandated to ensure that public health is protected with Superfund investigations and cleanup. And so that's our main role with Superfund sites. And so this consultation looks at exposure potential, we estimate risks, and we do this in consideration of, can everybody hear me? Because I know I have a soft device. Okay, great. We do this in consideration of community concerns, community characteristics, and we use all this information to identify what we think may be data gaps that need to be filled in order to protect public health. And in this document, we'll offer actions that may need to be taken to protect public health. We do this, typically we do this alongside EPA's risk assessment, but because he's trying to get these systems in place and protect the human health, the residents and business owners, we're a little bit behind, and partly for that reason, but also ATSDR just has a really rigorous review process, and they've got now a reduced workforce as well as increased requirements on reviewing. So it's going to take a little bit longer. We expect to document out hopefully the first part of 2026. We were kind of looking at the end of 2025, but it's looking closer to 2026. We may be surprised and be able to get it out sooner, but that'll be a public review. There'll be a public review period for people to look at that. Right now, we're in the early stages of our consultation. We're evaluating data that have been made available to us. We typically don't collect our own environmental data. We get it from the agencies. And again, it's a complementary process with EPA's. Their purpose is to develop cleanup levels and make decisions around remedial actions that are needed. Our purpose is to just ensure that public health is protected based on what they're doing. And we work in conjunction, we're in partnership all the time. We review EPA documents all the time. We're in the process the whole time, not just sort of this one little piece. We try to show up at community meetings. I live in Billings, so it's easy for me to show up if I'm not traveling. Is there anything else that I can think of.
Well, the other thing is what could potentially happen, I'm not saying it is just given the size and the number of impacted people, there could be potential that people could come to RiverStone saying, I have symptoms. I think it's a result of the Superfund site. Dawn is your point of contact, that if somebody does come here, that she would be the one that would be contacted to deal with anybody who comes for those.
And-
The other thing I wanted to say is, RiverStone Health is within here. And
Roger, I did make those dots. So RiverStone Health is the first orange dot right here. That's where we are right now. And then the second dot here is Building Central Catholic High.
Yeah, Building Central Catholic High already has a mitigation system. It's not, we need to expand it just because, when you look at a mitigation point, it's only going to pull so much. And the size of the campus, we're going to have to put additional ones in. So we know that. But what I would like to offer up is this winter, we have a mobile lab. It's called a trace atmospheric gas analyzer, and it would come in the basement and the first floors and kind of do an inventory. And if that's something, John, that you would like us to do, just so that we can kind of give you a clean bill of health, I'll be happy to set it up. I would need an access agreement. It's not something I need now. We can work with it when, it's probably like February that we're going to do the investigation.
No, let's get it set up for sure. The other question I had for DKHHS, is there a registry? Is there a symptom list? Are there illnesses that we're worried about? I have a friend, we have a colleague whose child just battled childhood lymphoma and lives in area A or B. And, have we created anything that shows any cancer clusters, any illness clusters within or related to the site?
Yeah, we don't keep a registry. The only registry at DPHHS would be the tumor registry. So, and that's in actually a separate section from me, but the information comes out of the hospitals. And so cancers are tracked. And I'm not sure if all cancers or just certain cancers, but otherwise, no. And then if there are concerns, our team, one of our roles is to provide technical assistance, not only to the different agencies, local, other state agencies and federal, but also citizens. And so people are welcome to call. Don't tell everybody the whole town to do this, but they're welcome to call us, and we can either talk through what's going on. We can sometimes offer like a mini letter where we may look at the data specific to their location and look at their symptoms and see if there could be some connection. And in this process, we would be required by our federal partner to review that. We are not allowed to provide medical advice or anything like that, but we can, present the information that we have and have ATSR help us decide if there's a connection. It's really tricky with some of these, right? Like especially the central nervous system effects. It could be caused by so many different things, as are the cancers. But so yeah, that is sort of the avenue for people to seek help.
So you're primarily for radon.
No, actually, it's tetrafluoroethane is what we're looking at, but the mitigation approach is a radon mitigation system.
What is the mitigation system? What's involved in that?
It would depend on the structure. So a lot of people may have a crawl space as opposed to a concrete foundation. So a concrete foundation would be, you would drill into the concrete, put a suction point in, and I'm going to do it on a residential because basically one suction point has a radius of influence that could probably cover a 1,200 square foot foundation. And so that's called a subslab depressurization system. But a lot of times you may have concrete and earthen, or you may have an earthen foundation. And in that instance, you put PVC pipe and then you cover it with, some type of liner, and then that's used to kind of draw it out. The other thing is a lot of times, given the age of some of these homes, most of these homes were probably built before the 1960s. Your foundations have a lot of cracks in them. And as part of the mitigation approach, we're going to go ahead and seal all the cracks, both on the walls as well as. So that's the approach. Did that answer your question?
And there's some kind of a little pump or something, and then it vents it outside.
Yeah, it vents it outside. And one of the things Brianna and I talked about is, if I have 700 mitigation systems running, am I making it a outdoor air issue? And what we agreed is it's probably going to cost us just as much to investigate whether or not we have an outdoor concern than just put a kind of like a granulated activated carbon that would filter the air before it gets released. And when Brianna and I were kind of working on the alternative, we agreed that, and it also meets state guidance, that it's better just to treat that air before it's released to the outdoor. So John and on Monday, I was supposed to call both of you to let you know, is this meeting good enough as formal notification, or would you prefer a call on Monday when we actually release the proposed plan?
Formal notification to public health?
Yeah, I would call you and say we released a public plan. What I could do is, rather than call you, once the proposed plan is released, I'll shoot you both an email to say, here's kind of the information. You can share that with the board. Should that work?
Yeah.
Would that work with you as well? Okay.
Are you planning to brief the city this
July 7th. Yeah. With the public meeting July 23rd. And the fact sheet will go out, I want to say, just right after July 4th.
Time of year, does it affect how much you can, when you, like, you're gonna check the foundation here, like, cold air, does that make it like, what means the last year? Like this time of year, testing.
This time of year, testing indoor air is not advised, mainly because, not everybody has air conditioning. So, you're gonna open your windows, you're gonna put fans in, you're gonna kind of, the air exchange is going to be a lot greater than in the winter time. So that's when I said we're coming in February to do sampling. That's the worst. If we're going to see it in the indoor air, that's most likely. And what I do want to emphasize is, even though we're putting mitigation systems in, the indoor air in most of those structures is not impacted. It's the level that are underneath the structure that we're concerned about. And, I could say, hey, you got extremely high levels underneath your foundation. I'll be back next year to sample. And then, well, it's still not in your indoor air. Let me come back next year and sample. It is so much cheaper just to put the radon system in than to inconvenience a tenant and a property owner multiple years to determine, oh, now the indoor air is a problem. You get the mitigation system. So we just feel it's more cost effective for us and more protective of public health.
Thank you. Other questions for the group? Thanks, Roger. Thanks, Don.
Sounds good. I'll give you an email on Monday. Okay.
That's good.
I'll be real quick, because I know we're.
Do you want to wait till August, or you want to do it now?
No, I don't think we need to wait. I'll just say, on page 104, you have a report. this report summarizes a pretty extensive survey that we participated in with state HHS. The overall gist of this effort is to try and work with the state and county local health departments to really enhance the local health department's capacity to perform the core public health functions, which are listed in that report on page 2. And then the gist of our survey results is, as you would expect, because we're a fairly good-sized health department, we're the largest local health department in the state. If you go to page 7 of that report, you can see how our health department kind of operates relative to similarly sized jurisdictions in terms of meeting the criteria, so to speak, of performing the basic or core public health functions. We met 100% on all but 2. And so with those 2, we are working on, always continuously improving ourselves, but we're focusing on improving in those 2 areas. So I'll just leave it at that. And if you guys read through it and have any questions, Melissa, me, feel free to email us.
Thanks, sir.
Yep.
Your 30 seconds left for comment. Anybody want to say something? Anybody other than Michael want to say? We only have 30 seconds. Hearing none, we are adjourned.